This is Dr. Kamal. Thank you for watching my videos. Today we will talk about anemia. It will be general approach to anemia first. This video will talk mainly about iron deficiency anemia, how to diagnose, and also how to treat between the different forms of oral iron and IV iron and when to use each. There will be another series of videos to go through all the different types of anemia and how to diagnose and treat them. So let's start with some basics. So we have iron hemoglobin biochemistry. So you probably know that we have hemoglobin is just heme and globin. And globin, we have alpha 2 and beta 2 globin, and it's a tetramer, which mean we have four of this, and each one of the globin bind to heme. And heme, it's just a porphyrin ring, and inside this porphyrin ring, there's Fe2 positive, which is the iron. So each hemoglobin has four globin chains. Each one has heme group, and heme is just ring plus the Fe2 positive. It has to be Fe2 positive to be able to carry oxygen. If there's oxidation happening, like in cases of methemoglobin, so Fe2 positive will be Fe3 positive oxidized to Fe3 positive, and this will decrease the oxygen capacity to decrease the hemoglobin capacity to carry oxygen. Um, this is the adult hemoglobin again. Fetal hemoglobin is different. It has gamma chain instead of beta, which has higher oxygen affinity. So, between iron absorption, transport, and regulation, what basics you need to do to know to understand what we'll talk about further. So, dietary non-heme iron because iron can be bind to porphyrin, which will be heme, but the iron we eat from the diet, it's non-heme iron, which means it's not bound to porphyrin ring. And if it's not bound to porphyrin ring, it's Fe3 positive. And when it goes down to the GI, it switch to iron divalent or 2 positive by the duodenal cytochrome B because the iron channel or the iron receptor is actually divalent, so it cannot absorb Fe3 positive, it can only absorb Fe2 positive. And this channel or this part of the pathway can be upregulated by the HEF2 alpha, which we'll talk about differently in a different situation, but sometimes we use these drugs that can affect this pathway in CKD patients. So again, it's absorbed by divalent metal transporters. So any divalent um, m- metal, like other divalent metals like calcium, if there's calcium with the iron, sometimes the calcium can decrease the absorption of iron because it worked through the divalent metal transporter as well. And these transporters will be expressed in the duodenal interior sites. And the duodenal here is important because any GI pathology that would affect the duodenum would cause decrease in the iron absorption. Then this iron will be exported by ferroportin. So ferroportin, from the name ferro, iron portin, which will port the iron or transport the iron mainly to the plasma. And in the plasma, it will be transferred again or reoxidized to Fe3 positive because transferrin cannot bind to Fe2 positive, it only binds to Fe3 positive. Once it's bound to transferrin has two sites, so it can bind to two iron atoms. And then the transferrin circulate in the blood, then it goes to the receptors, and the receptors here would be the erythroid precursors like bone marrow, liver, and mainly the bone marrow, of course. And there is a receptor for transferrin to get this iron from the circulation into the bone marrow. And we have two forms of stored iron between ferritin and hemosiderin. And the main difference is ferritin is soluble, so it can be existing in the blood, soluble in the blood or the plasma, so you can actually measure it. While hemosiderin is just insoluble and it just accumulates in the liver, the spleen, and the marrow. And we have a regulator to the iron transport and absorption, which is the hepcidin. Hep coming from the liver, so it's mainly liver derived. And it does different things. So it's first, it can bind and can degrade the ferroportin. And what stimulate and what inhibit this is usually the iron content. So if you have, um, hypoxia or you are having erythropoiesis, you need to make more iron, then this hepcidin will be downregulated. And if you have inflammation or iron overload and you don't want more iron, this protein will be downgraded, upregulated or increased. So just to summarize, we have here the GI, esophagus, stomach, and we have here the duodenum, right? So what we eat is usually Fe3 positive, which will be converted to Fe2 positive in the duodenum and get absorbed by the ferroportin. Ferroportin will transfer this iron from the duodenum enterocytes to the bloodstream. And when it goes to the blood and the circulation, it will be in two forms, either stored or circulating. What circulated? The transferrin. And the stored mainly will be the ferritin, right? And the transferrin, it has a receptor which is called TFR1, which exists on the bone marrow to get this iron from the circulation to the bone marrow to create the RBCs and the hemoglobin, right? So this is the pathway before the bone marrow use this iron to create hemoglobin, right? And then we have this ferroportin is regulated by hepcidin. So hepcidin inhibit the ferroportin. So if you have a lot of iron, excess of iron, the liver will secrete hepcidin to inhibit the ferroportin to decrease the iron absorption. And if you have low iron state, that the liver will not produce the hepcidin, so you have less hepcidin, then the ferroportin can work and absorb the iron to correct the iron deficiency here. The problem with hepcidin, it can also increase in inflammation. So sometimes it has nothing to do with the iron, sometimes it's just the inflammation can increase the hepcidin, and this is acute phase reactant, so it's an inflammatory protein. So the hepcidin, if it's upregulated by inflammation, it will decrease the iron absorption. Okay, so this is just a brief summary about the iron pathway between absorption, transport, and regulation. Let's talk about some numbers. The hemoglobin, which is mainly important to classify and diagnose anemia. So we have different ranges between males and females. So males will be the normal range between 13.5 to 17.5. In females, it's less, so it will be 12 to 16. Pregnant, so usually if they have the hemoglobin should be above 11. If it's below 11, it will be anemia. And the main function of the hemoglobin would be oxygen carrying protein. So RBCs circulate in the blood. RBCs has hemoglobin, and the hemoglobin carries oxygen and goes to the tissue to provide oxygen to the tissue. So those are the different ranges for hemoglobin. Whether it's male, female, or pregnant, any hemoglobin below 7, that's considered severe anemia, and usually that's the threshold for transfusion. Then we have the HCT, and the HCT is usually 3 times the hemoglobin. And what does it mean? It's usually the percent of the blood volume that's occupied by the RBCs. So we have if we have here the blood, it has plasma, it has YBCs, it has different stuff, but what the HCT measures, it's the percentage of the RBCs in the total volume, total blood volume. MCV is just the RBC size. So if we measure the RBC size, normal range, the average between 80 and 100. The importance of the MCV, it's just a classifier. It helps us to diagnose or find out what is the cause of the anemia. So if it's below 80, we call it microcytic, and we have differential diagnosis for that. If it's between 80 to 100, that's normocytic, and if it's above 100, we call it macrocytic. The thing with the MCV, it can be falsely elevated in hyperglycemia or severe agglutination or dehydration, because imagine here the bloodstream, and we have different, we have the plasma, we have the different electrolytes, glucose, um, we have YBCs, platelets. So if the blood is more thick, or there's more other like electrolyte or solutes in the blood, the RBCs will be very close to each other. So it's really hard to know the exact size of each RBC versus if you have a lot of space in the plasma and you can really identify the actual size of the RBC. When we talk about MCH, so MCH, it's mainly we have the RBC, how much hemoglobin in the RBC. So how much hemoglobin in the RBC. So average hemoglobin per RBCs, and usually pairs MCV. So if you have low MCV, like in the iron deficiency anemia or thalassemia, usually you'll find the MCH low as well. So if this is low, this would be low as well. Versus the MCHC, which is concentration, so it will be gram per deciliter. So actual, how much hemoglobin concentration in the RBC volume. And it will be low in uh, low, we call it hypochromia, which is an iron deficiency anemia, and it will be high in spherocytosis or dehydration. RDW, it mainly represents the RBC size variation. Sometimes you have bigger, smaller, average. So this variation can be normally existing between this range, 11.5 to 14.5. But if there's high variation, that's usually iron deficiency anemia, but also can be B12 or folate deficiency. And as we will talk in the next slides, if the RDW is normal and you have low MCV, that's very you have to consider thalassemia because this is a pattern for thalassemia, and we'll talk about patterns in anemia in later slides. If you have high RDW and low MCV, this is mainly a pattern for iron deficiency anemia. And the RDW is really important because RDW usually falls first before the MCV. So you can have, elevate before the MCV. So if you have iron deficiency anemia, usually you'll see first increase in the RDW before you see the decrease in the MCV. Then we have the reticulocyte count, which is immature RBCs. And this can be helpful as well, especially in the normocytic anemia, because if you have high reticulocyte count and you have anemia, that means reticulocyte count mainly reflects how good the bone marrow is able to produce new RBCs. So if you have high reticulocyte count and anemia, this means the bone marrow try to compensate for the anemia, which happens in the hemolysis or the blood loss. So basically, you are losing blood, whether in the bloodstream, hemolysis, or external, like GI blood loss or menstruation or anything like that. The bone marrow will try to compensate by increasing the reticulocyte count to compensate for this blood loss. While if you have anemia but low reticulocyte count, that means it's hypoproliferative disease. There's a problem in the bone marrow, because if you have anemia, the bone marrow should increase the reticulocyte count to compensate for this anemia. Another thing, this lab doesn't exist in all institutions, but it's mainly the reticulocyte hemoglobin content. And this is, we'll talk about this later, but this is important in the functional iron availability for erythropoiesis. So sometimes you have good iron, but this iron is not available. Why not available? Because you have inflammation. So the inflammation decrease the transferrin, decrease the iron absorption. So sometimes you have iron, but you cannot use it. And we see this in functional IDA, or sometimes like an example for that would be anemia of chronic disease. So this can be helpful in CKD dialysis or pediatrics because it shows real time availability of how much actual iron is available for erythropoiesis. And this is really important, right? Okay, let's continue. Then we have reticulocyte production index or RPI. This is really important in normocytic anemia, as we'll talk about normocytic anemia in another video because it's an index and it's just you can calculate it. So if you can use MD Calc or just like Google it when you need it, which is mainly the RPI equals reticulocyte count multiply HCT over 45, which is the normal average normal divided by maturation factor. If you find the RPI more than 2, that means it's adequate compensation. That means the bone marrow is working good enough. And that means it's usually hemolysis issue or bleeding issue. You are losing blood and the bone marrow trying to compensate. If the RPI below 2, that means it's hypoproliferative state. There is a bone marrow issue. Okay. Um, then let's talk about the different iron measures. So we have the ferritin, which is mainly the stored iron. And we have these three different labs, which is related to the transferrin, as we'll talk in a little bit. So transferrin, mainly it's the stored iron versus all these different numbers, which will reflect the transferrin. So in the ferritin, actually, it's the best single test for iron stores. And we'll explain this point in a little bit in a next slide. So if you have ferritin below 30, that means you are depleted. You have iron deficiency anemia. And if you have below 15, I can swear you have definitive IDA or iron deficiency anemia. Although it's the best single test for iron store, the problem it's acute phase reactant. So let's say someone has, if they don't have inflammation, their ferritin would be 30. But if you have inflammation with iron deficiency anemia, the ferritin will increase. So you can see this number, for example, 100, 150, etc., because its increase doesn't reflect there is its increase doesn't reflect there is a lot of iron, it's just increased because of inflammation. So it's acute phase reactant, so it can be falsely normal or elevated, especially in inflammation, and sometimes in liver disease and malignancy as well. And we'll talk about this in later slides. Serum iron is a range between 60 to 70 and it's just circulate, see how much iron is bound to the transferrin. The problem with serum iron is diurnal variation. So sometimes if you measure it in the morning, you can find it elevated, but if you measure it in different time of the day, it can be a different number. And of course, if you have iron deficiency anemia, the serum iron will be low. And if you have anemia of chronic disease, you have low serum iron as well, because most of the iron is just stored in the ferritin and different tissues rather than being available on the transferrin to go to the bone marrow. And serum iron can be elevated in hemochromatosis, hemolysis, because your hemolysis, the RBC is getting broken, and the iron is just circulating in the blood or getting, back to the liver or the spleen. And it can be elevated also in sideroblastic anemia. All these different factors between TIBC, between TSAT, between STFR are related to transferrin. So transferrin is the protein that gets produced in the liver and circulate in the blood, and it has two seats. So it has two seats to bind iron, and it binds to F3 positive. So you have two seats that the iron bound to the transferrin. So TIBC is mainly total transferrin binding capacity, which means how much empty seats you have. You have two seats, right? How much of these are empty? Because if you have high TIBC, that means you have empty seats, right? That means you have iron deficiency anemia, right? So if you have high TIBC, that means the capacity to carry iron is high. Why? Because you have empty seats on the transferrin. That means it's iron deficiency anemia. And just um, and if you have also iron deficiency anemia, there will be increase in the transferrin to try to grab more iron. So you'll have more transferrin and more empty seats. While in ACD, or you have iron overload, you will see low TIBC, which makes sense. If you have a lot of iron, you have less empty seats because all these different seats on the transferrin is already occupied or not available. In anemia of chronic disease, there is low transferrin, so there is low available seats. Transferrin saturation is just the opposite. So Tsat equals serum iron divided by TIBC multiply 100. So here divided by TIBC, that means it's the opposite of TIBC, right? So, and what this actually means, how many seats are full. How many seats are full? It's transferrin saturation, right? So if you have high total iron saturation, that means you have a lot of iron that's attached to the transferrin and the seat. That means you have iron overload. And if you have the TSAT low, that means you have less full seats on the transferrin. That means you have less iron. The soluble transferrin receptor, we talked about this, the transferrin usually circulating in the blood, then till it goes to the bone marrow. And in the bone marrow, there is this receptor for the transferrin to get the transferrin from the circulation into the bone marrow to create the RBCs, which we call erythropoiesis, right? So the soluble transferrin receptor, sometimes it detaches from the tissue and just circulate in the blood. So this number is basically telling you how much the tissue or the bone marrow need oxygen. Why? Because just imagine if the bone marrow and the tissue need oxygen, they will upregulate this receptor just to get all the transferrin they can find in the blood circulation. So if you have high TFR, that means you have iron deficiency anemia. And this is a really good important marker because it's not elevated with active inflammation versus ferritin. Ferritin is the best single test for iron stores, yes, but it can be affected by inflammation. But this is not acute phase reactant, so it's not affected by inflammation. So if you have high index for the STFR, that means you have iron deficiency anemia. The haptoglobin LDH and indirect bilirubin are more related to hemolysis, which will create normocytic anemia. So if you have RBC that's get broken and distracted, and everything inside gets outside, this will increase the LDH, and this will increase the indirect bilirubin. But also the haptoglobin is this protein that binds to the free hemoglobin after hemolysis. So if you have lysed or broken RBC, you will have high LDH, you will have high indirect bilirubin, but low haptoglobin. And this is very, very sensitive marker to hemolysis. So haptoglobin is very sensitive marker here. So let's read this. Haptoglobin binds free hemoglobin after hemolysis, and it goes to the liver to be cleared. So if you have low or absent levels of haptoglobin, that means you have intravascular hemolysis. That means you have the haptoglobin consumed, so you have low levels. But also, it's a mainly protein that get produced and cleared in the liver, so it can be low in liver disease. LDH, it released from lysed RBC, so it will be elevated in hemolytic anemia, but also it can be elevated in B12 deficiency or TMA. In direct bilirubin, the normal range will be below 1.2, and this is a product of heme catabolism. So if you have RBC that get hemolyzed, how to get rid of like this heme, it will be converted to indirect bilirubin, which will go to the liver to give the direct bilirubin, and after that, the bilirubin will be cleared in the body from the GI and the kidney. So it's elevated in hemolysis. But if the elevation is very high, usually above 4 or 5, that it's not a hemolysis problem only, it's also a concomitant liver disease, or there is a liver disease going on beside the hemolysis. So think about if the level is so high, that means you have increase in the production, but also decrease in the clearance, right? Okay. Let's talk about some early markers. We talked about this briefly as RDW as early marker, and the importance of the reticulocyte hemoglobin content. As I said, is not available in each institution. So usually, again, in iron deficiency anemia, the RDW go higher before the MCV go low. So it can be an early marker for developing iron deficiency anemia. The reticulocyte hemoglobin content, it reflects real-time iron availability for erythropoiesis, and it can be helpful in patients who have functional um, iron deficiency, like patients on CKD, um, and those patients, usually the ferritin and TSAT can be misleading because of the ongoing inflammation of the CKD. So you want to know how actually much iron is really available for erythropoiesis. So you do the reticulocyte hemoglobin content. Again, RDW also can be really important to distinguish between thalassemia and iron deficiency anemia, because both can cause microcytosis or low MCV. But if you have low MCV and very high RDW, that's more consistent with iron deficiency anemia. If you have very low MCV and normal RDW, that's more consistent with thalassemia. Okay, so now we talked about the iron, different levels. So let's talk about anemia, right? What is the threshold to call someone having anemia? It differs between men, women, between pregnant and non-pregnant. So the numbers you should remember: 13, 12, 11, 13, 12, 11, 13 for a male, 12 for non-pregnant female, 11 for a pregnant female. And the children, they have a range which is lower than males also. So children up to 59 months and the hemoglobin below 11, that's anemia. Between 5 to 11 years, below 11.5, between 12 and 14 years, below 12. So now we diagnose the anemia, right? We found the hemoglobin, we have a male, and the hemoglobin is 11.5, so it's below 13, so that's anemia, right? So the severity of the anemia determined by how much is the hemoglobin decrease. So we have grade 1, which is the hemoglobin anywhere between 10 to the lower normal range. So 10 to 13 in males and 10 to 12 in non-pregnant females, and 10 to 11 in pregnant females. Grade 2 is hemoglobin between 8 and 9.9. Grade 3 is hemoglobin below 8. And grade 4 is usually life-threatening, and that's usually below 7, right? Then we'll talk about signs and symptoms that can happen in anemia in general. So if you have mild anemia, that's usually asymptomatic. If you have moderate anemia, usually generalized symptoms like fatigue, palpitation, dyspnea, and all that. If it's severe, which is below 8, usually they can get chest pain at rest, they can be lightheaded, sometimes also syncope, right? Some specific symptom clues: if someone is having pica, which is mainly ice craving, that usually a pattern for iron deficiency. If someone is having restless leg syndrome, iron deficiency is the most common cause for restless leg syndrome. Someone has a lot of inflammation in their mouth and tongue glossitis, that can indicate iron deficiency, but also B12 and folate. If they having neurological symptoms, particularly in the distribution of the posterior and lateral column, that can be indicative for B12 deficiency, which we differentiate that from the folate, which you don't have these neurological symptoms with the folate, right? And these symptoms can occur without anemia. So if someone having B12 deficiency, they can have neurological symptoms even before developing anemia. If someone having dark morning urine, that can be a pattern for intravascular hemolysis or PNH. Someone with jaundice, jaundice means high bilirubin and splenomegaly, which is the side of the RBC's breakdown. So that means this combo means there is hemolytic anemia. If someone having bone pain and frontal pulsing, that can be in thalassemia measure. Mainly, you have decrease in the RBC production because the globin is low, so you're trying to recruit more bone to create more blood. So these were some symptoms, some signs. We have the pallor between different sites, the conjunctiva, palm, nail bed, but the conjunctiva is usually the more reliable. If you have anemia, that means you have less RBCs, you have less hemoglobin, you have less oxygen that the blood is carrying to the tissue. So in order to compensate, the heart increase the cardiac output by causing tachycardia to increase the perfusion that's going to the tissue. So sometimes we will call it high output state or high output heart failure, and this can come with systolic flow murmur. And the main etiology here that you have less with the anemia, you have less oxygen going to the tissue, so the heart is trying to compensate by the tachycardia to cause increase in the cardiac output. Sometimes you can find spoon nail changes. And also, again, icterus and splenomegaly, it's just different words for the jaundice and splenomegaly, which means you have some hemolytic etiology. If someone have lymphadenopathy and hepatosplenomegaly, sometimes that can indicative of malignancy. Again, thalassemia, frontal bossing, orthostatic hypotension, that's usually volume problem, so significant acute blood loss can cause orthostatic hypotension. What are red flags for anemia that need urgent evaluation? It would be chest pain, dyspnea at rest, or altered mental status, and that needs admission. If someone having hemoglobin below 7 with symptoms, you have to transfuse. And usually you find symptoms if they have fatigue, like it can be any symptom here. Anyone with hemoglobin below 6, they have to get transfusion. And if there's hemodynamic compromise, which means you have low blood pressure, or you have high heart rate, decreased oxygen saturation, and the anemia, that also need emergency intervention because they can be in hypovolemic shock, right? So, classification of anemia. As we talked, the MCV, the main importance of MCV, it helps us to classify the anemia to try to narrow down the possible differential diagnosis to reach the diagnosis eventually, right? Okay, so according to the MCV, the normal range between 80 to 100. So if in that range, that's normocytic. Below that will be microcytic. Above that will be macrocytic. The microcytic anemia, as we'll talk, this video actually will be mainly about the microcytic anemia and the iron deficiency anemia specifically. So if you have microcytic anemia, that means you have in the hemoglobin production, there is a problem in the hemoglobin. So if you have RBCs or RBC. This RBC, it has hemoglobin, it has protein, it has DNA, it has some water. So if you decrease the hemoglobin content in the RBC will be smaller, so microcytic, right? If you have normocytic anemia, that usually means either you are losing blood, hemolytic, or decrease the production. So decrease production or increase destruction. So that usually will create normocytic anemia. Macrocytic anemia will be differentiated to megaloblastic and non-megaloblastic. Megaloblastic is usually a problem in DNA synthesis, which you can see in B12 and folate. Okay, and I will not get into the biochemistry of that, but there is a big explanation for this. The non-megaloplastic is usually a problem in ingredients or like TSH or bone marrow disease or copper deficiency, other etiologies, right? Okay, so let's talk about microcytic anemia. So microcytic anemia, we said the MCV will be less than 80. So if you have microcytic anemia, there is hemoglobin problem. The actual hemoglobin, there's a problem in it. So there's decrease in the hemoglobin. Globin is alpha 2, beta 2, and we have tetramers, so multiply 4. And the heme, it's just a porphyrin ring, and there is Fe2 positive here. If there is a problem in the porphyrin ring that we see in sideroblastic anemia, or sometimes in lead poisoning. Sometimes it's iron problem. So if it's iron problem, it can be the iron is deficient, which is in the IDA, or the iron is available, is in the, like, it's not deficient, but it's not available because you have high hepcidin in the inflammation process. And that's what we call functional IDA or anemia of chronic disease, right? So mainly those are the causes of the microcytic anemia. IDA, problem in the iron, IDA, anemia of chronic disease, problem in the porphyrin ring, sideroblastic, lead, problem in the globin as a protein, so alpha thalassemia and beta thalassemia, right? So first thing, we want to see the iron status of the patient, right? And in iron status, we'll order different blood work between ferritin, TSAT, and iron and TIBC. If the ferritin is low, the ferritin is the best marker for iron because it reflects iron stores. So if the ferritin is low, that means automatically it's iron deficiency anemia. The threshold for the ferritin can be 30. Some references would talk about 45 as a low level for ferritin. So if you have low ferritin below that range, you have iron deficiency anemia. Okay, congratulations, you diagnosed iron deficiency anemia, but the problem is why they are iron deficient. So why they are iron deficient? It's gonna be one of two things, either decrease absorption or increase in the blood loss, right? Decrease absorption, someone have, the iron get absorbed in the duodenum. So if someone has celiac disease, they have, a problem in the duodenum, or they had surgery, they remove part of their duodenum, or there's a lot of inflammation or ulcer that can decrease the absorption, right? Or you are absorbing the iron, but also you are losing it. So increased blood loss, the most common site for blood loss anemia would be GI, and sometimes in female it will be menstruation. So if you diagnose iron deficiency anemia, you have to find the source. GI loss would be the most common, but also in women or female patients, they can lose the iron in menstruation. So workup mainly is around why they have iron deficiency. You can look at the blood in the stool. You can do endoscopy or colonoscopy, upper endoscopy or colonoscopy to look for any side of bleed. Or if you are concerned about celiac syndrome, you can get the IgA trans tissue glucosamine or the different markers to diagnose celiac serology. Sometimes they can be losing that in the urine, so you can do urine analysis as well, but this is way less common. Okay, what if you have high ferritin level, which I say here the ferritin is above 30, right? So if you have ferritin above 30, that doesn't exclude automatically iron deficiency anemia because we said ferritin can be elevated in inflammation. So what I want to know first, if there is inflammation or not. Second, different markers for iron. So if ferritin can be falsely elevated, we look for different markers. And if you find inflammation or you find the different markers are decreased, then you can diagnose iron deficiency anemia. We'll talk about this in a little bit. But again, if you have inflammation going on and the ferritin is high and the TSAT is low, that can be anemia of chronic disease in the setting of the inflammation, right? And in this case, you need to treat the underlying etiology. Sometimes they can have mixed pattern between ACD and IDA. So if the ferritin is below 100, like 80s, 90s, for example, or the TSAT plus the TSAT below 20, that means it's a mixed pattern between ACD and iron deficiency, and in this case, you can give iron. If no, the ferritin is above 100, the TSAT above 20, there is no inflammation, then it's probably on the other side between thalassemia or sideroblastic anemia, but it's not iron. So here, the inflammation and the TSAT mainly helps to differentiate anemia of chronic disease versus iron deficiency anemia. Okay, so if you have inflammation, you have different markers of iron that are low, even the ferritin is high, that can be a diagnosis of anemia of chronic disease. We'll talk about the differences in a little bit. We'll talk about the normocytic and macrocytic algorithm in a different video, but let's talk about microcytic anemia and the different labs that you can see in microcytic anemia. So in microcytic anemia, you either has a problem in the iron. So we have heme and globin. Heme is iron and porphyrin ring. So IDA and ACD mainly, it's decrease in iron, right? So decrease in iron, either it's not available or it's not deficient. Then we have the sideroblastic. It's a problem in the heme, but it's not a problem in the iron. It's a problem in the porphyrin ring. So you have iron accumulation because the bone marrow keeps getting this iron from the circulation to create RBCs, but there is no porphyrin ring. So this iron keep accumulating in the bone marrow and in the circulation. So between IDA and ACD, there will be different markers of iron, but generally it will be decreased. But in sideroblastic, it will be increased. In the thalassemia, it will be mainly normal because it's not an iron problem at all. It has nothing to do with the iron or the heme. So you have a problem mainly in the globin, which is the protein. So here you have a heme problem because the iron is not available or deficient. Here you have a heme problem, which is because of the porphyrin ring problem. And in that situation, the iron accumulate, and you can see the different markers of iron high. But here it's actually not heme problem, it's globin problem, right? So between IDA, ACD, thalassemia, and sideroblastic, MCV will be can be low in all of them, right? But usually in IDA and thalassemia will be more decreased. And actually, thalassemia decreased the MCV way more than the IDA. Why? Because if you think about it, in the IDA, you have a problem in the heme, but in the thalassemia, you have a problem in the globin, and by sense, the globin has a higher volume than the heme. So the MCV, the RBC, would be smaller if they don't have globin. Otherwise, or in comparison with if they don't have iron, they will be yes small, but not as small. Then the RDW is really, really important marker, especially to differentiate between IDA and thalassemia. So we have high RDW in iron deficiency, but normal in thalassemia. because the variation in the RBC side, that's mainly in iron deficiency, but it's consistent. You have, if you have a problem in the globin gene in thalassemia, mainly the RBCs would be small but consistent. So all of them will be small, but the variation in size will be uh, not as much. While in iron deficiency anemia, it will be small, but there is high variation in the size. Then again, as we talk, the serum iron in anemia of chronic disease and iron deficiency anemia, you have decrease in the serum iron, while in thalassemia it's normal, and in sideroblastic it's high. The TIBC sometimes it's a good marker to differentiate between IDA and ACD because TIBC can be significantly elevated in IDA but less or normal in ACD. So again, total iron binding capacity, it measures how empty are the transferrin. So if the transferrin seats are empty, that means you have iron deficiency anemia. But if um, the seats are normal or decreased, that will be mainly in anemia of chronic disease. And why you don't have empty seats? Because you have low transferrin to start with. So TIBC can be helpful here because IDA and ACD both will have low serum iron levels, but TIBC will mainly elevated in IDA versus anemia of chronic disease will be low or normal. Then we have the ferritin, which reflect the stored iron. So in our anemia or iron deficiency anemia, you have low ferritin, you have low stored iron, but here you have normal, and here you have iron excess because you keep absorbing this iron, but you cannot use it because you cannot put it on a porphyrin ring to produce heme, right? Then the TSAT, which reflects how full are the transferrin or the transferrin, how full it is with iron. So it's, of course, it will be low in iron deficiency anemia because those seats on the transferrin are not full, are not saturated because you have iron deficiency anemia. But also in anemia of chronic disease, it can be low, and then mainly here, it's not because you have less iron, it's mainly because you have less transferrin. So if you have less transferrin, that means you have less available seats. So here, in thalassemia, will be normal. In sideroblastic anemia, it will be high. The nephro the um, next marker would be mainly for thalassemia. So it will be hemoglobin electrophoresis. So hemoglobin electrophoresis, it will look for the globin, right? So if you have high HbA2 more than 3.5, that means beta thalassemia. Because if you have beta thalassemia and you have decrease in the beta globin, what will happen to the alpha 2 or the A2 globin? It will increase to compensate for the decrease in the beta globin. So in the thalassemia, if you do hemoglobin electrophoresis, the HbA2 will be more than 3.5. What if it's alpha thalassemia? So alpha thalassemia, the hemoglobin electrophoresis will be normal. So in that case, you need to do DNA testing. Okay. And of course, in iron deficiency anemia or anemia of chronic disease or sideroblastic, that would be normal because they have globin, they have alpha 2 globin and beta 2 globin. It's not a globin problem, right? It's a heme problem, whether the iron is not available or deficient or the porphyrin ring. So these are heme problems. Sometimes also the blood smear can be um, helpful because in IDA and ACD, you'll see the hypochromic pattern. In thalassemia, you can see those target cells and you can see still microcytes or small RBCs. Um, in sideroblastic, you can see those ring sideroblasts, which you need to stain with Prussian blue stain to be able to see those ring sideroblasts. Another thing to differentiate between iron deficiency anemia versus thalassemia, one important marker will be the RDW. The another thing we call it Mincer index, which is mainly MCV divided by RBC count. And if it's more than 13, that's more consistent with iron deficiency anemia. If it's below 13, that's more consistent with thalassemia. And of course, in all different types of microcytic anemia, if you give iron, there is no response. But if in iron deficiency anemia, you can give iron and it will respond. And this is mainly sometimes it can be confusing. There can be different things going on, and you're not exactly sure what's causing the microcytic anemia. So, what you can do, you can empirically treat this patient for iron deficiency anemia and see the response to iron. If they have iron deficiency anemia, they will respond to iron. If they don't have, then you have to. If they don't respond to iron, you have to evaluate for different etiology. So let's talk about this stepwise. You diagnose a patient with microcytic anemia, what to do next. So you look at the ferritin, as we said, if it's below 30, that's consistent with iron deficiency anemia. If it's borderline between 30 to 100, it can be still iron deficiency anemia. So what you do here, you look if there's inflammation and you look for other iron markers, other iron markers. So you can add TSAT, you can add STFR, which we said it can be elevated in iron deficiency anemia and is not related to inflammation, or if you want to see any inflammatory marker like CRP. Again, if you have MCV that's very low with RDW normal, suspect thalassemia. And if you're suspecting thalassemia, you need to do the hemoglobin electrophoresis, but you also can calculate the Mincer index. If the Mincer index below 13, that's again consistent with thalassemia. If it's consistent with thalassemia, you'll need to do hemoglobin electrophoresis. If the HbA2 above 3.5, that's consistent with beta thalassemia. If it's alpha thalassemia, the electrophoresis would be normal, and in that case, you need to do DNA testing. If you have microcytic anemia, but the iron is high, ferritin is high, TSAT is high, so all the different labs for iron are high, that's more consistent with sideroblastic, right? And if you have sideroblastic anemia, to confirm the diagnosis, you will need bone marrow biopsy and stain it with the Prussian blue stain for the ring sideroblast. If you diagnose iron deficiency anemia, the most importantly will be the source. You can look for decreased absorption or increase the loss. So it can be GI bleed, it can be decreased absorption like celiac. So you can do anti-tissue transglutaminase IgA. Sometimes it can be menorrhagia as well. You cannot just treat the iron deficiency anemia without finding the cause. And as we said, the most common cause for blood loss and iron deficiency anemia will be GI blood loss. So any adult male or postmenopausal, because the menstruation here, if they having menstruation, that can explain the blood loss. But if they are postmenopausal, that will not explain blood loss. So those kind of patients need really comprehensive GI evaluation between lower GI evaluation and upper GI evaluation to exclude any GI malignancy or ulcer or anything like that. If you do the endoscopy and the colonoscopy, and sometimes you need to do even capsule, and you don't find any source of bleed, so you need to think about different causes of iron deficiency anemia, which can be decrease in the absorption. And actually, celiac disease is a common underdiagnosed cause for refractory IDA. And usually, what happens here, you diagnose patient with iron deficiency anemia, you're giving them usually oral iron, you're giving them oral iron a lot, but you don't see a response. And the reason you are not seeing a response because they have decrease in the absorption, because again, celiac disease can affect the duodenum, which is the site of iron absorption. So in these patients, you need to check anti-tissue transglutaminase, right? And remember, in alpha thalassemia, the electrophoresis would be normal, and you need to do DNA testing. So actually, there are three stages of iron deficiency. So not all iron deficiency will cause anemia. And the thing is, you have three different phases of iron. Let's say we have stored iron, which is represented by the ferritin. We have circulating iron, which is represented by the transferrin. And you have erythropoiesis, or the bone marrow iron that can be used for erythropoiesis and the hemoglobin. So initially, stage one in iron depletion, you will have low in the stores. Stage two, you will have low stored iron, but also low circulated iron. And stage three, you will have low stored, low circulating, but also start to affect the hemoglobin production. So stage one, you will find only the ferritin is low, which means you have low stored, but you still have good circulating, and this circulating going to the bone marrow enough to normalize the hemoglobin. And here you don't have hemoglobin issue, so the MCV will be normal, right? So if you see someone with normal hemoglobin and MCV normal as well, but the ferritin is low, so that's an early sign of iron depletion. Stage two, you have decrease in the stored iron, which is represented by the ferritin. You have decrease in the circulating iron, or the transferrin iron, which is represented by low TSAT, but still the bone marrow is able to get some iron to keep the hemoglobin normal, and most of the time you'll see normal MCV as well. Stage three, it will be iron deficiency anemia, which will be you'll have the stored iron low, you'll have the circulating or the transferring iron low, but also the bone marrow will be affected at this point to cause anemia, which will be diagnosed with hemoglobin below 12 or 13, and it will be microcytic, so the MCV will be below 80. Again, ferritin is really important here. So ferritin is the best iron marker. And why it's the best iron marker? Because of this, because the first number that will decrease in iron deficiency before even causing anemia will be the ferritin. So it's the best marker ever for iron. But the problem with ferritin, it can be falsely elevated in inflammation. So that's the problem, right? So we still need to rely on ferritin, but when it's not consistent or there's inflammation, we need to think broader, right? So if someone, general population, and there is no inflammation, and you see the ferritin is below 30, and also the TSAT will be low, so that's iron deficiency anemia. What if there's inflammation? So in cases of inflammation, like it can be heart failure, HFrEF or HFpEF, it can be CKD, whether dialysis or not dialysis, whether inflammatory bowel disease, whether like cancer or whatever, you have to have higher threshold for the ferritin. So you can diagnose iron deficiency anemia with higher ferritin because you're expecting the ferritin to be high because of the inflammation. So in these patients, so if someone having inflammation like heart failure, and you see the ferritin is below 100, then that means they have iron deficiency anemia and you need to give them iron. What about the ferritin is between 100 to 299 or 100 to 300? So they still could have iron deficiency anemia, but the ferritin is falsely elevated because there is inflammation, which is the heart failure here. So you need to look for other markers of iron. So what you look for, the TSAT. So even if the ferritin is elevated and they can still have iron deficiency anemia, and you can diagnose that if the TSAT is below 20. The same concept with CKD, and the same concept also for the hemodialysis patient. But even the hemodialysis, they get some blood loss, so you have a higher degree for or higher threshold for iron deficiency anemia. So it will be below 200 plus TSAT below 30. In inflammatory bowel disease, if they don't have inflammation, then you will treat them, or like the threshold will be at the normal population. If they have active inflammation, then the threshold will be 100. And also you look for other markers, which will be the TSAT will be below 16. In cancer, it can be whether like below 30, that would be absolute iron deficiency anemia. But if the ferritin is between 30 to 500, you look at the TSAT. If the TSAT is below 20, that means it's iron deficiency anemia. In pregnancy as well, you diagnose it below 30, but you try to target higher level in pregnancy. So you try to target ferritin above 50. In ICU or acute setting, again, ferritin is acute phase reactant, so you should less rely on ferritin and more rely on other markers like the TSAT. You can also calculate the STFR over CRP ratio. So SFTR, as we talked about, is the transferrin receptor on the tissue and the bone marrow. If the bone marrow is not getting and the tissue is not getting enough iron, these receptors can detach and you can measure it in the blood. And it's a reliable marker for iron deficiency anemia that's not affected by inflammation, but also you can get the CRP to calculate or see how much inflammation they might have. So again, this is a really important distinction between absolute versus functional iron deficiency. In absolute, you don't have iron. In functional, you have iron, but you cannot use it because it's an inflammation state. So in absolute IDA, there is true depletion of iron stores. So you'll see the ferritin is below 30, but also the iron markers will be abnormal. So the total saturation or transferrin saturation will be less than 20, and the TIBC will be elevated, and you expect those patients to respond to iron. In functional IDA, you have uh, adequate total body iron, but you are unable to deliver it to the tissue and actually use it. And in that case, the ferritin can be normal and can be high, so you need to rely on other markers like the transferrin saturation. So sometimes even if you have normal ferritin or high ferritin and the TSAT below 20, that can be a diagnosis for some deficiency of IDA. And this can happen in anemia of chronic disease, CKD, active IBD, CHF, and active cancer. And again, this index, the TFR over the log of ferritin index, if it's above 2, that means you have true iron deficiency anemia versus functional iron deficiency. We diagnosed iron deficiency. Now it comes to how to treat iron deficiency. So iron replacement will be between oral and IV, and it comes in different forms, so it can be a little bit confused. So let's start with iron therapy. So iron therapy will be first line for stable. Someone doesn't have inflammation, because if they have inflammation like celiac disease, you can give them oral iron, but they will not absorb it. So you need to use it in non-inflammatory IDA with intact GI absorption. And there is some evidence support that you can give alternative day. And the reason here to give every other day versus to give daily, because it's mainly about the hepcidin. So if you have increase in the iron that's reaching to the duodenum, that can stimulate the hepcidin, and the hepcidin can decrease the absorption. So we have different forms of iron between ferrous sulfate, gluconate, fumarate, and maltol. These three forms are salted iron, which means there is salt with the iron. And each form we'll talk about how much actually elemental iron in the dose you are giving. So, for example, ferrous sulfate, you give a dose of 325, but only out of the 325, you have 65 milligram of elemental iron. And again, we give these, we give it every other day. It's really first line because it's cheapest, it's best studied. Um, and you can just like give it to a lot of people. The problem is it has more GI symptoms. So more GI symptoms because actually the ferrous sulfate detach and give free iron in the GI, and this free iron can irritate the stomach, so it has more GI side effects. And again, the reason we are using every other day is just to decrease the hepcidin and increase the net absorption. Um, Ferrous gluconate, it has better GI tolerability. So if you start with ferrous sulfate and they have some GI upset, nausea, vomiting, constipation, you can switch to ferrous gluconate. The problem is you have less elemental iron in the ferrous gluconate. So here you have 65 milligram, here you have 36 milligram. So these patients, instead of every other day, you usually give the pill every day. Um, Ferrous fumarate, it has really high iron content, which is 106 six in the 324 milligram dose. So you give it once daily. It has high elemental iron. So it's available as liquid for pediatric and pregnancy. Mainly here, it has a smaller size. So in pregnant patients, they take a lot of vitamins. So if you want to give them iron, the iron tablet is usually very big. So if you want to give them a smaller size or incorporate it in multivitamin, you have to make it smaller. So what ferrous fumarate give high dose of iron in a smaller pill. And the thing is, you have high elemental iron, you have 106, but actually, this high elemental iron content can stimulate the hepcidin and decrease the absorption. So, just given higher content doesn't mean they have higher absorption, and this pill need to be once daily again. Ferric maltol, it's not a salt, it's just iron pill or iron attached to maltol. So it's a 30 milligram capsule. And the thing is, it has better GI tolerability. Why? Because of the dose. First, the dose is less. So here you are given 65, here you are given 36, here 106. This is just 30. The second thing, it's not a salt, so the salt can irritate the stomach, but here actually in ferric maltol, it keeps bound. So the iron keeps bound to the maltol, it doesn't detach and cause this iron irritation to the GI mucosa. Since it's a smaller dose, you need to give it twice daily, right? You need to increase the frequency. Um, when you give iron, When you give iron, you are expected the reticulocytes to rise first at 7 to 8 days. Then the hemoglobin will increase 1 to 2 points within 2 to 4 weeks. After you start the patient on iron, you need to correct the hemoglobin, but also to correct the ferritin above 50. So sometimes even the hemoglobin corrects or normalize, you need to give extra 3 months supply of iron to correct the ferritin, which reflect the stored iron. If there is no response at 4 weeks, you need to reassess adherence if the patient taken it, if there is a absorption problem like celiac, or they have ongoing loss, or this patient might need, if they have inflammation or severe anemia, they might need IV iron, which we'll talk about in a little bit. Sometimes also The iron can be not effective because of the reduced absorption because of secondary, like other medications, calcium and acid. Remember that calcium is divalent, so it will compete with iron on the same transporter. Antacid and PPI will decrease the acid which is needed to iron absorption. Sometimes you can give this patient vitamin C with iron as well to enhance the absorption, and also tetracycline can decrease the iron absorption. So that's oral iron. When to use IV iron? IV iron, you'll use it when you use oral, but you have severe intolerance or failure, malabsorption issue, significant ongoing blood loss, or they have inflammation, which we call functional IDA, CHF patients, CKD patients. If you want like a faster result, like preoperative optimization, IBD with active inflammation, and sometimes in second or third trimester of pregnancy with severe iron deficiency anemia. So all the different IV iron will differ in the dose and the frequency, infusion time, and if you need to do a test dose. And test dose, historically, the classic iron was the high molecular weight dextran. So that's the classic iron. And because it's higher molecular weight, these patients sometimes will go into anaphylaxis. So um, what happens if you want to give specifically the dextran, you need to do a test dose first. You give a very small dose to make sure they don't have anaphylaxis to that particular type of iron, but that only apply to the dextran. It doesn't apply to the other forms of iron. So if we start with the first iron is ferric carboxymaltose or injectifer, and this the dose usually it's 750. The maximum dose will be 100 1500, and you can give two doses. Each dose is a week apart. So this is really good in the outpatient setting. Why outpatient setting? Because in the outpatient setting you need higher dose and less frequent or less visits. So actually, these two are good for the outpatient because you can give higher dose and less visits. And the infusion time, if you are given 750 those, it's usually infusion time more than 15. The 500, it can have longer infusion time just because of the dilution when they dilute it with fluid. Sometimes it's just institutional, they dilute the 500 with higher fluid than the 750. The main problem of the ferric carboxy maltose, or just briefly FCM, this is briefly FDI. So FCM, the problem, it can cause hypophosphatemia, and it's actually common. So it happens in 20-50%, and this is mainly in this form of IV iron. So you need to check the phosphate after 1 month to 3 months after the infusion. If someone has baseline hypophosphatemia, then try to avoid this form of iron. And there's a lot of studies about use of FCM in CHF patients, actually. The second form is FDI, and again, this is a good form to give in the outpatient setting because it's a higher dose and less visits. So you can give, there is no absolute maximum dose, so you just dose it based on the weight. So if someone is 100 kilogram, they can take up to 2000 milligram of iron, and it can be just single dose visit. So again, it's appropriate for the outpatient. And there's just 20-minute infusion. And again, you don't need to test dose because only test dose for the high molecular weight dextran and the dextran. So the thing is, it's the good thing about it, it has large single dose and low hypophosphatemia risk. Next one is iron sucrose, who went from like 1500 and 2000 in FDI to 200 to 300 as a dose in iron sucrose. Usually you give 5 doses and it lasts 15 to 60 minutes. So this will be good for inpatient, right? Because if the patient's staying for 5 days or more, you can give just the iron sucrose. And it has excellent safety profile, widely used in CKD, whether dialysis or not dialysis, can be used also in pregnancy. But just because if it's a smaller dose, so it needs multiple infusions. And again, since it's a smaller dose, so the safety profile and the side effects is less, so it has excellent safety profile. So went from 1500 and 2000 to 200, then here we have 125, which is the ferric gluconate, and usually they get it for longer infusion, or it can actually give as an IV push, 10 minutes, so it's a slow IV push. And the main thing, it's slow dose, so that's why you can give it as a push. And is the standard for hemodialysis patient because it can be given during dialysis session. But since it's a smaller dose, you need multiple doses, right? So those two are not good options for outpatient, right? The Ferahim, it's 510 milligram to doses 3 to 8 days apart. I don't see it as common because it has this black box warning. It can cause serious hypersensitivity. So if you are given it, be available, like be ready to do like some resuscitation measures if they have severe anaphylaxis. The classic iron is the dextran. It used to be high molecular weight, and the high molecular weight can cause anaphylaxis. But nowadays, we don't use the high molecular weight anymore if we use dextran because it's usually cheaper. We can use the low molecular weight. So the low molecular weight, even if low molecular, you need to do some test dose because there is still have some anaphylaxis risk. Yes, it's less than the high molecular weight, but it's still higher than the other forms of IV iron. There is a formula called Ganuzzi formula, which is to calculate how much actually the patient need iron. So iron deficit calculation, which will be weight in kilogram multiply the difference between the target hemoglobin that you want to reach minus the actual hemoglobin, multiply 2.4, and whatever dose you get, you add 500 to it again to replete the stores, to increase the stores. The same concept for the oral iron when we said you need to give for extra 3 months after you normalize the hemoglobin just to replete the stores. The same concept here in the IV iron. So, for example, someone having 70 kilogram as weight, their hemoglobin 8, you're targeting 14. So you do the equation, you find they need 1500 milligram. So you need, this is a very high dose. So you need to use FCM or FDI that we're talking about that allows higher doses. Um, if you don't want to calculate this, if you want just a simple estimate, usually most adults with moderate iron deficiency anemia, they need between 1000 to 1500 milligram of total IV iron. You can choose if you are given it FCM or FDI, it would be less visits or less infusions. But if you, for example, given the ferric gluconate, then they might need like 10 infusion. So there is different forms of iron. So let's just try to summarize it. So iron, we have the oral one and the IV. Oral, we always start with sulfate, iron sulfate, right? So we always start with iron supply, sulfate. It's 3 to 5 every other day. If they don't tolerate it, no GI intolerance, we can switch from sulfate to gluconate. And the reason it has better GI tolerance because it has less elemental iron, so you need it to give it actually every day. So just remember these two, sulfate and gluconate, 325 and 300. Then when it comes to the IVB, the IV iron, it will differ in how much dose you are given and the visits. So if you are in the outpatient setting, you will give outpatient versus inpatient versus CKD on hemodialysis. So outpatient, you have the FCM or FDI. Why FCM or FDI? Because you can give high dose with less visits, right? You don't want them to come every day for an infusion. So you give high dose and less visits. FCM, you use if someone doesn't have any hypophosphatemia risk. If someone has hypophosphatemia risk, you give FDI. In the inpatient, you give the sucrose, iron sucrose, and iron sucrose usually would be 5 doses, 200 to 300. The CKD, it will be the gluconate and gluconate, which is 125. So it's usually every single time they go to have the hemodialysis, they can get the gluconate. So if you just recognize, once we go this way, we move from outpatient to inpatient, and usually here you have higher tolerance, less side effects because it's smaller dose, right? And here you will see the dose is usually high and less visits or less frequent, so it can be a better option for outpatient. I really hope this video helped you to at least identify how to diagnose anemia, the different differential diagnosis for microcytic anemia, how to identify iron deficiency anemia and how to actually replete it, and to understand the different labs that can be confusing in iron deficiency between ferritin, TIBC, TSAT, and all the other numbers. Thank you for watching.